Okay, so now we'll discuss the von Willebrand disease. Well, there are different types of von Willebrand disease, that is type 1, in which there is a partial quantitative defect, type 2, in which there is a qualitative defect, and then we have the type 3, which has the severe quantitative defect. But its phenotype is variable, and it has an association with the von Willebrand factor gene mutation. The inheritance pattern is highly variable. First of all, it will be transmitted as an autosomal disease, but it will be variably dominant or recessive, and genetic counseling of the female should be done for its transmission, variable penetrance, and then the expression. The risks of von Willebrand disease in the mother are antepartum hemorrhage and postpartum hemorrhage, whether this is a primary or secondary postpartum hemorrhage. And there is an increased bleeding tendency, especially if the type 1 von Willebrand disease, and if the levels are less than 0.5 international unit per ml. But the bleeding risk can also be increased in type 2 as well as type 3. So how do you manage this case in a pre-pregnancy or antenatal management? Before conception, you have to check the bleeding phenotype of this patient, whether it's type 1, type 2 or type 3. Then check the historical diagnosis, and the response to desmopressin should be established. The safe management is to follow an MDT, that is multidisciplinary team approach, and also check factor 8 levels at booking, then at the second trimester, and before any invasive procedure. And along with factor 8, also check the von Willebrand factor levels or its activity. Type 1 von Willebrand disease, after normalization of the levels, these patients should be delivered in a standard obstetric unit, in which there is a collaboration with the hematology center. But for the type 2 and the type 3, or in severe type 1 diseases, they should be delivered in a high specialist center with hematology centers. Okay, so for spontaneous miscarriages, and in order to provide a cover for surgical procedures, the von Willebrand factor and the ristocetin levels should be more than 0.5 international unit per ml. If the levels of factor 8 and von Willebrand factor are less than 0.5 international unit per ml, you offer them desmopressin, but then you prefer restriction of fluids for 24 hours. Desmopressin is avoided in preeclampsia because of the fluid retention, and if further fluids are needed, then you monitor the electrolytes for hyponatremia. Counsel the patient that if she is having type 2 von Willebrand disease, she can also develop a thrombocytopenia after desmopressin. For the concentrate replacement, it should have been taken from a safe plasma. Viral testing and inactivation procedures should be applied on it. The target peak levels should be 1 international unit per ml for labor and delivery. For most antenatal procedures, single dose is enough, but if needed, second dose can also be given 12 to 24 hours later. Intrapartum, well, the pre and post treatment levels should be checked, and they should be repeated after delivery, or if the labor is prolonged. Transamine can be given per orally or even intravenous route. Before delivery, it can be started. There can be platelet transfusion need in case of the type 2 von Willebrand disease, in which desmopressin was given and it caused the thrombocytopenia. Mode of delivery is decided upon the obstetric factors. If there are no other obstetric factors, spontaneous vaginal delivery can be performed. For type 2 and type 3, the external cephalic version, ventouse and mid-cavity forceps or fetal blood sampling and fetal scalp electrodes are avoided.